The knowledge base of what we do in medicine needs to have advanced to the point where you understand what a cell secretes, how cells communicate, and what growth factors are, and what an exosome is, and the different types of things. The medical industry as a whole, and in particular, I think big pharma, realized very early on that cell therapy was the way the human body works, and they had to get ahead of the narrative before the science of using your cells to help you heal got kind of out of control. Hello, everyone. Welcome back to the Zero Downside podcast. Feels like a bit since we've been here. Everything's all set up and ready. The last person to, of course, be ready is me. Everyone else is here. But for me, as you can see by the table ahead of me, what happens is we start talking about what do they want me to give them some content on, right? What is the topic? What's the question? What's the overwhelming issue that's kind of bubbled up over the last few weeks that everyone else is in the office is having trouble maybe answering some questions on? I think it's probably the best way to look at it, because there are times where, let's face it, most of the people in my office have heard profuse alliteration from me on all the different topics, and nothing is more gratifying to me than when they're talking to a patient or answering a question and I can hear my words recited back. We laugh, and it's became kind of a joke in clinic that one of my favorite things is to be quoted, and it's kind of being smart aleck, but at the same time, it's so true, right? When you hear, it feels like your message hit, right? So when you hear someone using my words to describe a treatment or a disease, it is incredibly gratifying to know that if nothing else, that people around me are starting to grasp the why of our thought process on the way we address things. And that's incredibly gratifying. And by the way, it makes me feel extremely confident with the way our patients are communicated to, that the staff has worked really hard on putting together a very complex set of scientific data, and the, poor kid inside me kind of data of being able to take a complicated set of facts and explain it in a way that's more approachable. And that's the goal of this podcast, actually, and that's what we were talking. This is one of the things that is pretty easy to get me provoked with, if you want me to spin out of control and go down a rabbit hole, is what is the real reason for the podcast, and why aren't there a lot of other outlets for this type of research described in layman's terms? And the reason that there's not a lot of other outlets, or really it's even worse than that, the reason that there's just not access to this information is because it's all about controlling the narrative. When you limit access to information, you limit people doing anything with that information, because people would act on information and facts. And that's how you make your decisions during the day. When you're trying to interpret what you're going to do for the day, what's going to give your day purpose, you're reacting to and making decisions based on a set of facts that you have become acquainted with. And even if your facts are wrong, which that's the point of this podcast, is we're going to try to help people get some of what's actually fact and science instead of what's turned into a narrative. The fact that physicians, medicine, your guidance counselor to healthcare, whether you see a nurse practitioner, a PA, a chiropractor, a family practice doctor, functional med, internal medicine, someone is ultimately responsible in your mind for some of the decisions you make. And you're taking communications with someone that you're counting on to know what they're talking about, and you're extrapolating the data from what they are talking about to make decisions on what you're going to do and what medicine to take or what vitamin to take or what procedure to have or what surgery to go through. I think that it's very difficult if you don't have a wide range of resources to gather your information from to make the right decision all the time, and especially when the data set of what's published has been artificially and sometimes very organically. Like there's some really complicated wording in some of the literature about how a stem cell works, because they go down a big rabbit hole on extrapolation of all these different growth factors and what is the chemical pathway to generate that. And that's really important if you're trying to reproduce the experiment, but it's not really important if you're trying to understand what happened, the discussion, the conclusion, the follow-up. Now, do I think that there's a lot of failure in the discussion and conclusion obtained by some of these articles? Well, certainly. Do I think that if I understand the pathway and the chemical analysis, what they're doing, it makes it easier for me to interpret their discussion and conclusions for a patient? Yeah, and that's kind of my responsibility. I went to medical school for a really long time. I have a science degree. I have a background in a lot of hardcore scientific study. I took embryology. I took microbiology. I did all that background work because I need to be able to take all that scientific study and turn it into some clinical information that's relevant for a patient. And that's a physician's job. That's why you go to medical school. That's why you are supposed to read. That's why there's continuing medical education. That's why there's so many journals published. And we talked today, clinical neurology, one of these articles, that's not a journal I take. I take a lot of journals. But these are data that I will still go on big searches for to find out what's the overwhelming outreach of anything new that may have been published. And what I'm going to do when I find something new is I'm going to go to its literature search and I'm going to deep dive on some of the articles that they use to make that opinion. When you do that, someone needs to make some of this information more accessible and easier digested by a patient relative to what's available to treat my problem, right? That's what this all really comes down to. Hey, Dr. McKenna, have you ever heard anything to do with stem cells and X? And I can say, yeah, you know what? Matter of fact, there was a paper published on this, right? That's my responsibility. And so really when we get on some deep dive, it's because someone had a question and I know what my answer is. I know what's in the literature, but there are times where the question has come up enough that I need to check on myself. I need to research a little bit more. And so there's a lot of topics, at least a couple a week, that will send me down the 4 to 6 hours of sitting in a chair at a desk because you get kind of lost and you look up and everyone's already in bed. And I missed out on dinner and I didn't say goodnight to anyone else. And there's something because I got trapped and my family, well, you guys have seen my middle daughter talk to me about those Einstein moments, or the mad scientist moments, because I'll be at the desk and I'll have 50 notebooks surround me, a couple open textbook, 2 computer screens between the laptop and the other because I don't want to lose where I'm at, and I'm bookmarking a bunch of stuff. And I don't really know how to work all the bookmark part, so I'll have to have either Aubrey or a research tech and scribe in the office, or my daughter, or Hannah, or some. Here's my computer bookmarks. Can you guys find all those and print them off for me because I want the hard copy of the article, because it seems like that sometimes you take this big deep dive, you find this great article, and it kind of disappears and you can't find it again. and I'll know the keyword I'm looking for, but I just can't get it to come up because it didn't come up under that keyword. It came up under the literature search and someone else's bibliography, and that's how I got to the article. And so I will take that dive because I'm interested in making sure patients have the right information. And oh, by the way, what normally happens is I come in pissed off because I'm just generally disappointed with how much is really out there, and we're still getting the question like it's some quack experimental. Well, Dr. McKenna, they said the use of stem cells wasn't really going to help. And da, da, da. Okay, I totally get that. But let's look at what's published. How about that? Because when you start looking at what's published, it can push a clinician who is passionate about delivering a reproducible result for a patient, or even if you're just passionate about the appropriate delivery of information to a patient. Once you start reading what's already been published and you see how long we've kind of known this, right? Like there should be, especially in the age of the internet, when you're not going to a library and using the Dewey Decimal System to look something up, or you're not counting on looking at a magazine every week to find what articles are in it. When you can do a literature search on topic, on PubMed or Google Scholar, even DuckDuckGo and Brave, certainly not Google, Bing, or Yahoo, because you're not going to get any of this on an optimized, focused search engine when a lot of this has the word stem cell in it, and they downgrade and de-optimize those terms so hard. But you know what doesn't do that? PubMed, Google Scholar. Like, if your physician doesn't have access to PubMed and you ask them a question, if they're using WebMD or some generic search engine to try to find information for you, they're not finding the scientific literature for you. They're finding generally accepted clinical literature and the Western medicine narrative that may actually be completely contrary to the science. Or at the very least, if I'm going to give people credit for not being malintent, if I'm going to pretend they're not evil, if I'm just going to pretend, so, I think there's a difference between ignorant and evil. Evil is the purposeful withholding of information that would have been helpful. Ignorant is just, I don't know. I don't know is okay. But I don't know masquerading as I'm the authority is completely different. Then it gets really close to the evil suppression or the making excuses for your lack of knowledge. I don't mind if I'm talking to a doctor, say, you know what, I don't know, I haven't read, maybe there's something out there because it's been a while. And we'll have patients come in, they'll say, I asked my doctor about it, and he said he just didn't know because there's no insurance code for it, there's no approved procedure dealing with it, so, I have to do my own reading. That's fine. But when a physician comes and says, that's never been published, there's no data, all that's quackery, there's only two reasons for that. And I genuinely want to believe that it's just the lack of effort and their completely bought-in status to the narrative because they trust bad people. And I think that medicine as a whole trusts our benefactors and the people that are paying for the medical education and the publication of the books and the curriculum, that you trust them enough that you think, well, if there was anything out there, they would have told me. Well, how are they going to tell you? They're going to tell you by publishing articles in the scientific literature. So it doesn't have to be clinical explanation. Like, you're not learning this in the hospital because the hospital doesn't care about the scientific data. Most medical procedures and a lot of the interpretation of science that's kind of clinicalized or downgraded or diluted into, well, this is the rationale for why we do it. A lot of those people have never even read the rationale for why we do it. They've accepted the narrative on the science. So there are times where let's just go back to the science, right? Because I think that that's really important. And I kind of think that you owe it to a patient to do that every now and then, especially when they're counting on you as their source of information. I think that in our clinic, what happens most times is patients show up with more information than the residents, interns, or med students have that'll be following us around. The patient will show up asking more questions. Well, I have a question about BDNF, and the people that are responsible for knowing what that even means will have no idea. And the patient has a pathway and what cell secretes it and all this knowledge base because they have done the research. But sometimes doing all your research without the medical degree to intervene, there's no way from a lay perspective. Look, there's terms I'll have to look up. And I have been studying this for my whole life. And there'll be still times where I'll have to stop, look up some terms because I'm not sure on the way they're using that term and what it really means to the direction of a study. So I can't imagine being a mechanic, which if my car breaks, I have to take it in. If the light comes on, I have no idea what to do. So those people that are they've studied a lot on that, so they know all about that. But I can't imagine being out in another field of study and being responsible for this information when you or a family member are sick. So at the very least, your healthcare advisor or your physician, you should be able to count on to provide you maybe some alternate point of view, especially if what we're doing in the Western medicine narrative hasn't worked for you. And again, remember, I'm a doctor, I'm a surgeon, I'm a trauma surgeon. I did a fellowship, I did an orthopedic residency. I did a general surgery rotating internship before I did my residency because I didn't want to just be the resident that only knew about orthopedics. And I wanted to understand the surgical anatomy a little better of everything else. So I took a year before I even did the orthopedic residency to do general surgery. Did that help anyone? Yeah, every patient I talked to ever for the rest of my life got benefit of that extra year. Did I feel castigated or put upon like I was paying the price for it? No, because I genuinely enjoy the learning part of it, and I was young enough to handle the rigors of it. I could not survive the training at 61 that I put myself through in my 20s and 30s. It was an endurance test. It was a lot of sleepless nights, a lot of reading, and a lot of trying to keep up, and this kind of study every night after working for 14 hours. And oh, by the way, we'll laugh when we came in. My daughter has just very few things I say that entertain her anymore. And today, she pointed out that I was pulling all these articles out. And I said, it's just so hard because my job is getting in the way of my work. But that's what happens, right? That's what happens in life. That's what happens with your job. And you can't let the daily mundane part of your life interfere with what is the driving passion to your purpose, because the only way to live the best life possible is to have purpose and meaning. So anyway, for what that's worth. But the question that started all this today was about diabetic neuropathy. It was about neuropathic pain, not even just diabetic neuropathy, because neuropathy can come from all kinds of sources, cardiac. Matter of fact, sometimes, and we have a patient, his very first symptom of severe and near fatal heart failure was neuropathy in his feet and calves. In his 40s, experiencing severe pain into his bilateral calves and feet, went to multiple physicians. They couldn't tell him why. He finally got referred at the 5th visit, just as a lark, let's do an EKG, a cardiac function study. Less than 3 hours after that test, he was admitted to the hospital and never left before he had a heart transplant. Actually, because they couldn't find a transplant candidate for him, and he was in such severe failure, he had the Jarvik heart, and he still carries it around in a briefcase. So he had the Jarvik heart, piggybacked on his heart, that got him through till the suitable transplant was available. His only symptom was numbness and tingling and pain into his feet. Even after the surgery, guess what? The symptom that drove him to know what was going on didn't resolve, because just getting your heart transplant didn't fix the peripheral neuropathy and the neuropathic pain he had, because the heart was focused on, it was so diseased that the nerves had passed the point of being brought back with just a little better blood flow. And that's not how the heart works anyway. The heart's worried about the heart and getting blood flow in and out. It doesn't have a lot of control over angiogenesis or new vessels in the feet and legs. And honestly, the problem was dual, right? It's about loss of neurons and loss of blood supply. And I thought, going through medical training, that it was more about blood supply. And you've heard me say on this podcast a ton that angiogenesis, or what the cells secrete, is the real magic of a stem cell. That it's not necessarily about it becomes a nerve or provides isolated neuronal support. It's because the blood supply to the feet and legs gets so much better that the nerves can kind of heal. And that's how it can control the neuropathic pain. And that is really well published, but not a deep enough explanation of that problem, because now what I know is published is actual neuronal differentiation of those cells and specific enzymatic, amino acid, and peptide and protein support of neuronal growth and neuronal differentiation of the cells. So there's a dual way these cells act. It's not just about blood supply. It's not just about angiogenesis. It's about neurogenesis. And we're taught, again, that Western medicine background, that that's not possible. And that's not, that you have all the nerves you're going to have. There's no differential. There's no more cortical growth at a certain point. That cortex growth is impossible. You can't reappropriate parts of your brain for other functions. There's no cerebellar changes over time except for degeneration. That's just not the fact. And we're going to go through some of the literature that the post-ischemic stroke patient, the heart failure patient, the diabetic patient, by the way, we have a patient this last week. We've treated for polyneuropathy, peripheral neuropathy, with just injections of cellular volume into his calves several times over the last few years. But I could never tell him the source of his neuropathy, because with some of the lab that we've done and some of the studies that we've done, it really hasn't popped up. So this patient, who's from out of state, went closer to him and went to Mayo and spent 10 days there and 6 figures to try to figure out the source and treatment regime for his peripheral neuropathy, his painful polyneuropathy and painful neuropathic disease into his feet and legs. And after all that, they came back and said, well, it's idiopathic. So idio means we don't know, and pathic means disease. So after all that, and spending a week of your time and 6 figures, you get told you have peripheral neuropathy. Well, he knew that because in his own words, and what he told the physicians, the multidisciplinary approach that were being used to try to figure this out for him, what he told them is the only thing that's ever made a difference was the cells he's had in his calves, but his symptoms are dramatically better. They continue to improve, but he still continues to want more, because as he gets a little better and as he's able to go off more and more of his medication, the bar keeps going up on what he would like to have happen. And so at this point, he's not just despondent anymore about his painful feet. He's still working, he's still traveling, he's still doing everything he wants that he was ready to give up before his treatments. But now that he's starting to notice a difference, he's like, hey, maybe I've hit the top of the rung of what's possible right now with this. Let's go to the next version of medicine and see what they have. Well, what they have is a diagnosis that they still don't know the source of your polyneuropathy, and we may never, right? Because it can be such a multifactorial system. It's like asking, why did my hair fall out? Like, I can tell you a lot of reasons that it could, but I can't tell you the one that made yours fall out. I can just tell you some general reasons that it would, right? And that's the same thing with neuropathy. If you have heart failure, I can blame your neuropathy on that. If you have diabetes, I can blame your neuropathy on that. If you have cerebral palsy, MS, neuropathic diseases of all kinds, status post-surgery, you had spine surgery, and now you have neuropathy. Or you have not had surgery, but you have back pain and the secondary sciatica and neuropathy. I may be able to tell you the orthopedic causes of your pain, because that's what I do. I can definitely find all the other systemic causes that we could blame it on, but technically what you're still stuck with is neuropathy and pain. And I will tell you that on the Western medicine side of that, a lot of the neuroleptics, a lot of the drugs that are used don't even really have a great mechanism of action. So the gabapentines, the Lyricas, the peripheral neuropathy kind of medications of the world, the side effect profile on a lot of those is fairly dramatic. A lot of patients have to continue to dose up, and because it's a scaling side of you dose it till the level of effect. Some patients are on so much medicine that the side effect profile is so high, they just would rather suffer. Like, I'll just change my shoes, and I just won't walk, and I just will take something for sleep, and I'll just take pain medicine during the day, and I'll just do, because none of the other treatments made a difference, and the side effect profile of what they were doing was so high. What is out there for the neuropathic pain and the response of treatment to neuropathic pain if you use the biologics? And not surprisingly, because every time I do this, I function under the illusion that I would have already known if there was something great written. That's why I'm such an apologist for other physicians. Is, do I, in my heart, think that ultimately someone needs to be responsible for the literature when a patient asks you a question? Yeah, I feel very passionate about that. I think that you're their conduit to this information, and they shouldn't be held responsible for it. But do I think it's difficult to keep up with every different topic a patient's going to ask you? Certainly. And I'm not saying that your physician is necessarily evil or unlearned or ignorant if he doesn't know. But I'm saying that if he dissuades you from looking at the information, or if he's presented himself as knowing everything that's been published, then he is responsible for all this. And I've never done that because I wouldn't, because there is so much left to read. And in general, do I think that a lot of what is currently being studied, every time someone comes up with some study idea, that, a lot of, because of our involvement in the cellular technology, especially with the bone marrow harvest process, because one of these papers is actually published in the last 10 years and talk about how difficult bone marrow could be to obtain, and that's what's limited the science. I developed a really easy way to help draw bone marrow with a harvest catheter that's been on the market for more than a decade that makes the bone marrow harvest process about a 3-minute interval from an anterior crest where you're not laying on your belly, you're not having painful procedure done, and there's not a lot of clotting, and you can get reproducible cell counts, and I could draw enough marrow to matter from both sides if I need to. We've been doing it that way since like 2004. And so even the science being published now still won't, you can't know everything. So the people that wrote the scientific article about the theory of how these bone marrow cells work, and then the in vitro study, because they're harvesting it from rats, remember, right? A lot of the in vitro lab stuff or in vivo live animal models is still being done by guys that aren't surgeons and aren't having to draw bone marrow in a clinical situation and make it easy for you, right? So they're still talking about how hard it is and how painful and fraught with controversy and error. That's just not true. We've done over 20,000 bone marrow harvests with my catheter. The complication and side effect profile of that is extremely low. You can talk to one of the patients we've had on the podcast before. I think she said 6 or 8 different bone marrow draws, and she said there was only 2 of them she even had any bruising with, and that there was never an issue. And the overwhelming majority of patients, every patient that's had a knee scope or a shoulder done by me, anything north of a carpal tunnel that I've done for someone in the last 10 years, they've had bone marrow as a part of that procedure. And it's not uncommon that when they come in for their dressing change or the suture removal, they forgot about the bone marrow harvest site completely because it just doesn't have that much pain associated with it. So even when you're holding someone responsible on the scientific side, there's still a disconnect when it comes to connecting the scientific side to the clinical delivery mode. So again, I don't think that your clinician is purposely misleading you. Certainly, I think that the system can purposely mislead you because they have a financial incentive to distance themselves from any science that isn't sponsored by them. Like the problem with a lot of stem cells, especially patients' own bone marrow aspirate, it just doesn't have a good enough corporate sponsor, right? Like, because the intellectual property side isn't going to turn to a drug. It's God's IP, right? So he's not corporately represented enough in your congressman's office to get a Medicare code for something that could have made your degenerative disc disease go away. Because you know what does have a good corporate sponsor? All the hospitals, insurance, and orthopedic manufacturers that are going to profit from your disc surgery. And the secondary neuropathic pain you're going to have after your disc surgery's failure or the recurrence, because while you can take care of the pain, you can't make the nerve heal. And none of that really had to be true, right? So if that was represented by the right side of the equation and had a big corporate sponsor, probably you wouldn't have to be responsible for any of this, and you could go get care, and they would represent all opposing financial sides of the issue to you. But because there isn't a corporate sponsor of biology, you're kind of left on your own to kind of hunt and peck through all the data. The neuropathic pain data for peripheral neuropathy is extensive. And the way to look at that would be, even if you just look at, first of all, if you just put stem cells for peripheral neuropathy or stem cells for nerve pain or stem cells for, and this is the big, where most of this literature comes from, critical limb ischemia, CLI, right? So critical limb ischemia is the end stage of neuropathy where you start cutting people's legs off. And a lot of times in surgery, as an orthopedic surgeon, it's almost whittling. You start at a toe. You know, we used to laugh at, some of the, because you develop a very dark sense of humor sometimes when you're facing problems that seem daunting and unsolvable. You will develop a very dark sense of humor about diabetic peripheral neuropathy when you're cutting off a toe, because it's just like stage 1 of their BKA, right, which stands for below the knee amputation, or stage 1 of their AKA, which stands for above the knee amputation. And just so you know, just so we get this right on the CLI literature and peripheral neuropathy, here's what you're really facing. The metabolic demands of ambulating after 1 AKA are so significant that most people after and above the knee amputation aren't ambulatory within the first 2 years after that, meaning that you're in a wheelchair for the rest of your life because it takes the caloric demands, the cardiac health, the overall well-being it takes to ambulate with an AKA are so significant that the average person that needed the AKA doesn't have the metabolic support to stay ambulatory. That's a pretty dramatic thing. So that means you should probably try to avoid an AKA at all costs, right? Yes, and that's what Western medicine has tried to do with vascular perfusion exercises and all the vascular grafts and realignment and everything. But when surgery fails, and it does, as you can talk to anyone that's had a bunch of vascular grafts in their leg that it still has a big dead wound on their foot from their diabetes because it didn't return enough perfusion to keep your foot. There has to be something else, right? And so when you look at the CLI literature, there are hundreds and hundreds and hundreds of papers published. I found several review articles that were reviewing a 10,000 patient subgroup of studies that have been published on CLI. If there are 10,000 people that have been treated with stem cells for CLI and quite successfully compared to, and these were only patients put in the study in any of these review articles, all the studies that they're reviewing were only patients that had failed everything else. So again, that's back to the point I was making a minute ago. How did we get to the point where I started looking at alternative ways of treating a problem? And this is why I don't understand the Western medicine narrative against what we do. Because I'm not trying to find alternatives for solved problems. I'm fine with all the problems that I think that we've solved. I like the solutions we have. I like surgery. It's the only thing I've ever been really good at, and I gave away my 20s and half my 30s to do it. I can't replace the spark plugs in my car. You don't want me fixing a cabinet at my house. But if someone breaks something, or you have a bad knee, or your rotator cuff isn't working, that's where all my self-esteem comes from, is the fact that I worked really hard to try to be able to help a patient get better from those problems. When it came to the biologics, it's because there's so much of what I know and what the Western medicine narrative is that just didn't help a lot of people, or it didn't get them all the way over the hump, or it didn't get everyone better. Most medical treatment protocols are based on more likely than not in most of the patients. There's no everyone or nobody, because if it was nobody, that treatment kind of goes away. Well, you would think, but there are still a lot of really no one's helped by certain things that are done, and it's the only narrative out there because nothing else has worked. So we're just going to keep doing what we're doing, which is I get it. Do I think it's appropriate? No, if what you're doing doesn't work, don't keep doing it. And the argument of, well, that's what everyone does, or that's what's in the literature, or that's what WebMD said. Well, what did WebMD say about the success of that? Well, it says that a lot of people don't see much good from it. Okay, that is what drove me to the biologics, because there are so many things that we would do as surgeons that we knew the results weren't the same for everybody. If someone has diabetes, did they do really well from a crush injury to their foot where you can just take the front toe off and the wound heals and everything's great? No, they don't. It's just like the wound won't heal. The foot becomes more painful. They have hyperedemic swelling and lymphedema to the lower extremity where you can't even, it will literally weep with tissue fluid. And we don't have a treatment for that. Like lymphedema pumps and physical therapy and wound debridements, continual serial wound debridements, stage 1 of your BKA, right? The metabolic demands of a BKA, you're better off, you're more likely to be ambulatory after bilateral below the knee amputations than you are one above the knee amputation. So with critical limb ischemia, does it happen on one side more than the other? No, it can be really common that you have it. If you have it in one side, you have it in both. Because again, going back to our patient that we've made a fairly significant difference for with just stem cells into the calves using bone marrow aspirate concentrate. Did I come up with that on my own? No, it's really well published to make a difference. And the reason it's worth doing is because nothing else helped them. So when nothing else is out there, do I think a doctor should kind of go back to the drawing board and look at maybe it's not even clinical literature yet. Is there anything in the scientific literature that shows promise? Yeah, but some of this literature is described as showing promise in 1998. Do I think there's a certain point when you take it from might be clinically significant to doing it to people? I don't know what the appropriate time for that is, but I will tell you that if the side effect profile of what your proposed treatment is, well, here we go. The first drinking opportunity is pretty much zero. Like, what's the downside to your proposed care? If the downside of taking bone marrow aspirate concentrate and putting it in my calves is that it can't really hurt me, I can't have an allergic reaction to it, like, the downside is only the economics. And that economics are only important because it's not insurance covered, because they won't even cover an MRI a lot of time. Like, when people say, well, when do you think insurance is going to start covering it? I don't think they're ever going to cover it, because they don't even want to cover the things that already have a code for a lot of people. Anyone that's had to go through an MRI, there's a ton of people that you can't even get an MRI that have a knee that's locking, catching, giving way. The doctor said they needed an MRI that examined them. Their plain film shows some loose pieces floating around. The doctor can feel a loose piece floating around. You go to order the MRI, and the insurance company says, well, they need a month of therapy first, or you haven't tried a prescription anti-inflammatory, or they need to do this. So do I think they're going to get to paying for bone marrow for your neuropathy? Well, I have doubt. Let's put it that way, right? Because I think that they want to pay for less and less. Now, do I think that the self-insured plans, do I think your HSA, do I think that when you're interested in a result, that you're going to look at a lot of other options for you? I think absolutely, especially when your alternative is, what's the cost to you and the healthcare system of an AKA eventually for critical limb ischemia or for diabetic neuropathy or just continued pain? Never being able to sleep good again. Like, what's the economic cost of that to your employment, right? So the heart failure patient we're talking about got so bad and was on so many medicines for his neuropathy. Now he's grateful that he has a heart transplant, but he's getting ready to not be able to work anymore, not because his heart doesn't work, but because his legs are so painful and he has so much discomfort sitting in a car that he can no longer travel and be on the road as a salesperson to be able to do his job. And oh, by the way, he's taking 2 handfuls of medicines to control his symptoms. He doesn't even feel like he's safe driving a car. What was the downside potential treating that patient who found me because of the bone marrow, because he had done a deep dive and found that, there's some stuff out there on bone marrow aspirate concentrate for peripheral neuropathy? It was in the diabetic literature. He's not diabetic, but he has that heart failure neuropathy. Well, guess what? Diabetics have too. Diabetic cardiomyopathy, right? So diabetes can destroy all of that. Sometimes it's not the diabetes that destroyed it, but the symptoms are still the same, which is the case with peripheral neuropathy. Long story short, too late. When the cells make a difference for that patient, was it incredibly inspiring when the guy had hit a wall on all the other outlets that he had available in medicine? Yeah, it was incredibly inspiring. How long ago was that? 12 years ago? Have we treated a ton of patients with peripheral neuropathy symptoms, diabetic wounds, post-amputation patients, vascular patients that had failed their bypasses and now have critical ischemia. Is there any literature to support the use of stem cell science and the biologics on those patients? Yes, and it's overwhelming. And not only is it overwhelming, but it goes back quite a ways. This isn't stuff that we've been doing since last year. The bone marrow aspirate concentrate in simple orthopedic injuries. Like, I found some articles on this showing that the stem cells didn't even need to be necessarily put exactly where they needed to be to end up in the arthropathic joint. If you have a significant arthritis, they could provoke arthritis and cartilage death in a joint, put cells distant sites, and those cells would still end up in the site of osteoarthritis and the biggest inflammatory load. How's that happen? Because that's what they were designed to do. They find and fix. Well, why doesn't that just continue throughout your lifetime? Because your cellular volume, the health of those cells, and their ability to do their job is mitigated by a lot of environmental factors. How old are you? How healthy are you? What's your diet look like? That determines what your stem cells are capable of. You're going to always have less than you used to have, and the cells that you have aren't as good as they used to be. That's what the third law of thermodynamics says, right? Everything's in a constant state of decay. Nothing gets better with time. Now, can I take cells from someone else and use it to help you heal with allogenic cells? Yes. Is that extremely unsafe? No. Is there a lot of data out there on allergic reactions to postnatal tissue graft? Nope. It's immune-privileged tissue if you do it right. The chorionic side of the amnion can be antigenic. The amniotic side, the cord tissue, Wharton's jelly, the umbilical cord cells, even bone marrow aspirate that's typed and crossed. Is there antigenicity or allergic reactions or side effects or downside of using that graft? No, there's not. And so limiting people's access to cellular therapeutics, which is what I think is the best way for me to describe it, is the biologics, or what the cells secrete, or what the cells can sense and respond to. I think a better explanation of that is cellular therapeutic medicine, meaning that we're using tissue, primarily your tissue, bone marrow aspirate concentrate, concentrating it down and kind of putting it close to where it goes. Why would we do that? Because your body would love to be able to respond to that problem, but it lacks the resources. What we mostly are helping a person do is allocation of resources. You're using all your cells for heart, lungs, kidney, liver, gut, cerebral perfusion. It's kind of dropped the dead toe off of its to-do list when it's overwhelmed with the inflammatory load. It's kind of letting the nerves in your legs go a little bit because it's worried about cardiac function. Well, how do I get those back on the body's to-do list? Concentrate some cellular volume, get the right secretory factors, get that secretions and that biologics augmented and amplified to the point where it can make a difference for you. A lot like what you're trying to do with some drug therapy, but maybe a little more hit and miss than the body's own pathway is through these certain peptides secreted by these certain cells. Hey, what if we just put the cells where they could secrete what your body needs? Because we know these different pathways. The science behind this is really well delineated. We understand anatomy and physiology. Why can't we just help the body do a better job of what it would like to do if it could? Welcome to McKenna Orthopedics and Biologics, right? Like, that's Moab, Texas right there. Because that's all we're doing. I think there are certain things that I can't make better with biologics. You know what? The average carpal tunnel repair is a ligamentous release that takes 3 to 5 minutes through about a half-inch incision. Do I think that you should inject cells in the carpal tunnel to relieve the inflammation around the tendons because it results in some pretty significant relief of the symptoms? No, I don't think it's a great use of the graft. Had people had that done because they were having something else done and said, hey, can you put some of the cells there because my carpal tunnel's killing me and I don't really have time to have that fixed yet. I'll come back in a few months, but if there's any chance that could help. And have we done that with ultrasound, subligamentous, with some of the growth factors or the biologics, any of the tissue grafts? Yeah, and people got dramatic relief. Do I think that was the best use of the tissue when I could have had you asleep for 10 minutes, made a half-inch incision, and the complication side effect of that is extremely low, but it's not zero because it's still surgery? Could your wound have a problem? Could the stitch reject? Could you get an infection in the soft tissue? All that. Can you do any of that with a shot of the biologics there? No. You're not going to hurt anything as long as you do it right. And it's done by someone who knows what they're doing with the guidance and all that. No, I think the downside of that is extremely low, right? So you would almost say it has a zero downside. Number 3. But I think that there are certain problems I think that we're already solved. I don't think diabetic peripheral neuropathy is one of them. So let's go through and not just talking about diabetic, talking about peripheral neuropathy or lower extremity numbness, tingling, and pain. And the problem with it, if you don't have it or don't have a family member with it, is it's described as numb and tingle. It's painful. It burns. It hurts. So when someone says it's numb, it doesn't mean it doesn't hurt, right? So it's analgesia means numb enough to have relief. Paresthesia just means nerve dysfunction and pain. Neuropathy just means disease of the nerve. It's just not working right. It's not that it's just numb. Just numb, people will be thrilled with. Numb, burning, uncomfortable, achy, feeling like something's crawling on you all the time is not comfortable. And that's what people complain with neuropathy. It's not just numb. Numb would be fine. We wouldn't have done all this. Numb would be, hey, it could be burning, right? So the numb is better than when it just hurt all the time. But that's not it, right? It's not that it just eventually goes to where it doesn't hurt. It just continues to build up like a fire, and it won't stop until all the resources are gone, and including the extremity and the skin and the tissue and atrophy. And everyone with it has seen the muscle just kind of go away and see the strength disappear and see it continue to hurt more. When you start looking at what's been published, especially when you start looking at neuropathy, it's one of those moments where you feel incredibly rational in your approach when you see how much of the thought process has been backed up and for how long it's been going on. One of the better papers on that actually not only just confirmed what I felt, but dramatically expanded the knowledge base of the way the cells would affect neuropathy. And it literally talks about, the title of it is Dual Angiogenic and Neurotropic Effects of Bone Marrow-Derived Endothelial Progenitor Cells, or EPCs. We talked a lot in the science of what we're talking about with stem cells, amnion, umbilical cord tissue, bone marrow, fat cells. It is about nomenclature, right? And so when you're trying to compare apples to apples, it can be extremely difficult. And sometimes I feel like that's almost on purpose to dissuade you or discourage you from continuing down the rabbit hole. Because a lot of times, and we showed that with the vitamin C episode, is that sometimes they almost tilt the literature against it on purpose with the way they're doing the study. Like the only form of vitamin C that interfered with cancer treatment was a form of vitamin C that doesn't exist in nature, isn't commercially available, and has never been used by a physician. But if you did that, which why would someone do something that doesn't happen? It interfered with some of the chemotherapy regimes in mice. Well, because that way they were able to say vitamin C could interfere with your chemotherapy. Is that published at all in a commercially available form with a drug that a physician has actually used or a vitamin that someone could actually go to the store and get? No. Is it that way in the stem cell literature? Do I think that there are times where they'll say Well, we used fat-derived cells, or we stayed their culture below there, and it didn't make a difference. Yeah, there are times where I feel like that wasn't a genuine effort at making a response to their literature. They're trying to prove something doesn't work. Now, there are times in the literature, which is the studies I really respect, or where they're trying to prove something didn't work and they're shocked by the result. There's a heart failure study. They're trying to prove it didn't make a difference in this review article, which it was a review article of over 18 studies with 1,000 patients. And much to their surprise, just using bone marrow-derived stem cells, allogenic from someone else, there was a dramatic improvement in the left ventricular ejection fraction with 95% confidence. There was reduced infarct scar size with 95% confidence. And there was reduced left ventricular insystolic volume, meaning the heart was more efficient and worked better, with 95% confidence. Were they surprised by that? Sure were, because they were just reviewing the literature to show that it didn't make sense. In the review of the literature, what they concluded was the available evidence suggests that bone marrow concentrate transplantation, meaning the isolation of those EPCs, those endothelial progenitor cells, is associated with improvements in physiologic and anatomic parameters in patients with both acute myocardial infarction and chronic ischemic heart disease, above and beyond conventional therapy. Therapy with BMCs seems safe. I love the seems safe. Like, way to commit, guys. These results support conducting large randomized trials to evaluate the impact of BMC therapy versus standard care on patient-important outcomes. Wow, that would seem like we should get to that right away. Studies published a few years ago, right? Go back to this paper because I think this provides the foundation for that. And this paper, and this is probably the only one I'm going to go through in this episode, I will not spend so much time ranting. I'm trying to educate on what the diagnosis and definition of neuropathy means. We'll do a second episode here pretty quick where I'm just going to start off running. I'll give a short introduction referring back to this episode for the history, that I'll just go through all these articles because I think there's some really key points to make. And so by watching this episode, unfortunately, you've committed to another, because the second episode is where I'm actually going to try to hit a lot of these articles. But I think it makes no sense to go through hard clinical science and try to spend all my time describing a scientific experiment until you know the why, the where, the how, the who, and the actual patient important part. The only part that I think that needs to become from these articles is validating for knowing that you made a good decision. But more importantly, unless you're a physician going to be administering care, it's more just so you have some data sets to know that this stands a chance of making a difference, and maybe you need to not accept the narrative and just have dead feet and hurt and be addicted to pain medicine and let the medicines destroy your life because you're despondent and drug addicted and depressed, and you don't have to live with that. And that's the way all these patients eventually end up if they're not given hope and a solution, because it's a very difficult disease to provide patients relief from. So anyway, 2009, dual angiogenic and neurotropic effects of bone marrow. The most important part of this paper, and the part that, and it's a 35-page paper from the Journal of Circulation, 2009, Circulation, February 10th. We determined, and I love this because they actually step out a little bit, we demonstrate for the first time that bone marrow-derived EPCs could reverse various manifestations of diabetic neuropathy. Now, wait a minute, that seems like a pretty important sentence, right? Like, especially if it's from almost 20 years ago. We demonstrate for the first time that bone marrow-derived EPCs could reverse various manifestations of diabetic neuropathy. These therapeutic effects, and here's what I was getting ready to hear, These therapeutic effects are because of the angiogenic protein secreted by the bone marrow cells, and with better blood supply, the neuropathy can respond. Nope. Way more important than that. These therapeutic effects were mediated by direct augmentation of neovascularization. That's my angiogenic hypothesis, right? But in peripheral nerves through long-term and preferential engraftment of the EPCs in the nerves, and particularly the vasoneurium. And vasoneurium is the blood supply within that nerve fiber itself. So that's the vasoneurium. It's a part of the lining of the nerve. And their paracrine effects, meaning that, remember when we did the myokine episode on muscle, and we talked about how muscle can be an endocrine, a paracrine, and an apocrine gland. Well, apocrine means that it secretes something that makes itself better. Paracrine means it secretes something that makes surrounding tissue better. Endocrine means it secretes something that makes distant sites better through the blood supply. It's talking about the paracrine effect of the bone marrow aspirate concentrate stem cells actually made the paracrine, the surrounding tissue of the nerve, better. So it increased the functionality of the nerve itself. It's not just about angiogenesis. And I would have not felt comfortable going through the potential healing of neurons, the potential healing of the neuroganglion. Although we've seen dramatic improvement in a lot of that, I would not have felt comfortable saying that it's actually going to help the nerve heal. But that's what's published, is the nerve can heal. And it was the cells that did it. And that was presented as proven, being demonstrated for the first time. That's their words, with bone marrow aspirate concentrate. So I think that we'll probably end this here, because I know I went on a few different tangents, because I'm trying to, again, just like every time we talk to someone in our clinic, what I'm trying to do is give you some background and information to make a decision, and know that there's science behind what we're doing, and there's science behind other alternative points of view that may not be represented because it doesn't have the right corporate sponsor, and that there are times that just because someone throws shade on an idea doesn't mean that there's not good rationale and science behind it. And as it turns out, in almost every time I do this, the rationale and the science behind it are way better and way more prolific than what I've even studied and came to at this point. The harder I look for a downside to what we do, the more elusive that becomes. And I will continue to explore any potential downside, because I want to eliminate as many of those as we can for the patient. Anyway, at this point, I'm going to probably take a quick break from everyone, so that I can come back and just kind of plow through some of the articles for you. Hope if you're interested in that, click on the next episode, like, subscribe, maybe click a notification button for when that next episode gets put up, because it might not just follow right away with this one. But we genuinely appreciate your trust. Obviously, I'm not putting a lot of this extra work in because it has a code or the time isn't reimbursed. Again, sometimes the work and passion the job has gotten in the way of some of that. And I want you to know that the job and taking care of patients is still the most important thing to me. But I sure do like to be able to provide a patient with the right information and know that you're doing the right thing. Again, thank you so much for your trust. Hopefully you or someone you know that has or is experiencing or struggling with neuropathic pain, regardless of its source, at least has some sense that there are some things being done for that out there, and that have been being done for a long time, that could provide them some hope. So again, thank you again so much. Thank you for tuning in, and we'll continue to work hard for you. Thank you.